Welcome to The Explainer. Today, we're diving into a topic that can be a real clinical headache, evaluating and managing low bone mineral density in premenopausal women. Now, this is a whole different ballgame compared to how we approach our postmenopausal patients, and it really requires us to shift our thinking. So let's set the stage with a classic scenario. A young patient, just 32, and a DXA report lands on your desk showing low bone density. It's a situation we're definitely seeing more of. But the path forward, well, it's not so simple. This isn't just about writing a prescription. It's about putting on your detective hat and starting a real investigation. And why is it so complicated? Because in postmenopausal women, low BMD is a pretty straightforward predictor of fracture risk. But in a premenopausal woman, that same finding is just the very top of a diagnostic funnel. It's a signal, a red flag, telling us we need to hunt for an underlying cause. So here's our game plan for today. We'll start by really defining why this is such a unique challenge. Then we'll go on the hunt for those secondary causes. From there, we'll talk about the nuts and bolts of the workup, how to treat what you find, and finally, we'll tackle that very tricky decision of when and if to use medication. Okay, first things first. We have to completely reset our clinical framework. I mean it. The rules and the T-scores we use day in and day out for postmenopausal osteoporosis, they just don't apply here. And if we try to use them, we risk misdiagnosing and, frankly, overtreating our patients. This slide right here really gets to the heart of the matter. The ISCD guidelines are crystal clear on this. For premenopausal women, you have to use Z-scores. Remember, Z-scores compare your patient to her own age group, not T-scores, which compare her to a 30-year-old at peak bone mass. And a Z-score of -2.0 or less is not a diagnosis of osteoporosis. It's simply a description below the expected range for age. This is precisely why we don't do routine screening in this population. We just don't have the data to link a specific BMD number to their short-term fracture risk. So if the Z-score isn't a simple risk predictor, what is it then? Well, you should think of it as a bright, flashing warning light. It's signaling the absolute need to start digging deeper and hunting for an underlying cause. It's all about finding the why. And here's the crucial point. In over half of these women, you will find an active underlying reason for their low bone density. Some studies even push that number way higher, up to 90%. This is huge. It means our primary job is not to treat the BMD number on the page, but to find and fix that root cause. So what exactly are we looking for when we say secondary cause? Well, it's really anything that could have gone wrong along the way. It could be something that stopped her from reaching her full genetic potential for bone mass when she was younger, or it could be something that's actively causing her to lose bone right now as an adult. Our investigation has to cover both of those possibilities. And when you look at the possibilities, man, the differential is wide. We have to think across multiple specialties here. We're considering everything from subtle endocrine issues like subclinical hyperthyroidism or primary hyperpara, to GI problems like silent celiac disease, the huge impact of hypothalamic amenorrhea, and of course, a whole range of medications, with glucocorticoids being a major player. Okay, so with that massive list of possibilities, how do we actually approach this in the clinic without going crazy and ordering a million tests? Well, we need a system. An organized, systematic approach is absolutely critical so we don't miss anything important. It all starts, as it almost always does, with a really, really good history. I'm talking meticulous details. Menstrual cycle regularity, age of menarche, every medication she's ever taken, diet, exercise, and of course, family history of fractures. Then the physical exam is targeted, looking for those subtle clues, a hint of Cushing's, thyroid disease, or signs of malabsorption. Only after we've done all that do we move on to the lab work. This initial panel of labs is designed to be incredibly high yield. Your basic metabolic panel gives you calcium phosphate and kidney and liver function. We check a 25-hydroxyvitamin D, PTH, and TSH for the most common endocrine culprits. A celiac screen is non-negotiable because it can be completely silent clinically. And a 24-hour urine for calcium is key because it helps us sniff out hypercalciuria, which is a frequently missed cause of bone loss. And of course, if she's amenorrheic, you'll need gonadotropins and estradiol. And you always have to keep myeloma in the back of your mind, especially if there are fragility fractures. So the whole point of this exhaustive workup is to land on a specific diagnosis. Why? Because the management is absolutely not one size fits all. It has to be tailored directly to the specific pathophysiology that we've worked so hard to uncover. Let's use the biggest player as our first example, glucocorticoid-induced osteoporosis, or GIO. I mean, look at that quote, fractures enough to half of long-term users. That is a massive clinical problem that we see all the time. Glucocorticoids are just devastating to the skeleton because they attack it from all sides at once. They ramp up rank ligand to increase bone resorption, while at the same time directly suppressing the osteoblasts that form new bone. On top of that, they can cause hypogonadism, they mess with calcium absorption in the gut, and they even fight against vitamin D. It's a true perfect storm for bone loss. The good news is we actually have a clear roadmap from the American College of Rheumatology. First, make sure calcium and vitamin D are sufficient for everyone. Then you risk stratify the patient. If they fall into that moderate or high risk category, they need a bone active agent. And this is really important for our population. Both oral bisphosphonates like alendronate and risdronates and teriparatide are specifically FDA approved for treating GIO in premenopausal women. But now let's completely switch gears and contrast that with disorders of energy availability, like anorexia nervosa. Here, the playbook is totally different. The number one absolute cornerstone of therapy is not a drug, it's nutritional rehabilitation and weight restoration. And a critical point here, just giving back estrogen, which seems logical, doesn't work. It's been shown to be ineffective. And even weight-bearing exercise, which we usually love for bone, can be counterproductive in this state of severe energy deficit. Pharmacotherapy is really a last resort here, reserved for the most severe cases and used with extreme caution. So all of this brings us to what is often the most difficult clinical question of all. What do we do for the woman who has idiopathic low bone density, where we can't find a cause, or for the one whose secondary cause we just can't fully reverse? When do we pull the trigger on medication? Well, I can tell you one thing for sure. The decision is never, ever based on the Z-score alone. We have to look past that DXA report and really evaluate the patient's entire fracture risk profile. These therapies are not benign, and the stakes in a young person are very high. Generally, we reserve drug therapy for those with the highest short-term risk. We're talking about women who have already had fragility fracture or those we can see are actively losing bone on serial DXAs. But, and this is a huge but, before you even think about starting one of these drugs, there is an absolute requirement for a very frank conversation about future pregnancy plans. Bisphosphonates get locked into the bone matrix and stay there for years. That means they could potentially be released during a future pregnancy. This is a massive consideration and has to be at the center of your shared decision-making. In some of these really high-risk scenarios, like severe osteoporosis associated with pregnancy, clinicians are starting to explore our newer agents. And this recent case report using romosozumab is just fascinating. I mean, look at that, a 14.5% gain in lumbar spine BMD in just 1 year. That's incredible. But it also shows just how complex this is, because that same patient had a paradoxical 6.5% loss at the total hip. It just underscores that our understanding of how these powerful drugs work in this population is very much still evolving. And this really leaves us with the central challenge, doesn't it? For that 32-year-old sitting in your clinic, especially if she's already had fractures, you are constantly in this balancing act. You're weighing the known, immediate, and debilitating risk of another fracture against the unknown, long-term risks of our therapies in her young body. There are no easy algorithms here. There are no simple answers. All we have is careful evaluation, targeted treatment of secondary causes, and a deeply personalized, shared decision-making process for the individual patient right in front of you.